The conference would not be possible without our wonderful sponsors. And we'd like to acknowledge the sponsors now at this time.
Thank you all. Great introduction. You didn't have to read that all out. Oh, thank you. Okay. So thank you for inviting me. It's such a really great pleasure for me to be here today for many reasons. And I will quote two in particular. First, I think this is the very first meeting I'm having in person, maybe the second I'm having in person after the pandemic. Let's tell each other that we are really tired of Zoom meetings. It's so nice to be in person and to talk, with the people at the table and to have a cup of coffee together. So that's really a plus of this meeting for me today. But the more important one is that I'm talking to people with Parkinson's. I'm talking to the association, and I always try to do my best to explain what we do to the community. Doctors talk a lot, as you know, and they talk a lot amongst each other, and that doesn't necessarily help for many reasons, especially because then I think people out there feel kind of lost, and they don't really know what to look forward to in case of new advances in research, or what to ask their doctors. So I think it's very important that we have this exchange, and I'm really grateful that have given this opportunity to be here with you and tell you something about MRI-guided Fox Ultrasound today for Parkinson's. Since I have an hour to spend with you, which is quite a lot of time, I guess, for a lecture, I also decided to give you a few ideas on how doctors select the best therapies, the best advanced therapies for Parkinson's disease, because Fox Ultrasound is not just is not the only option we have. There are a few others, deep brain stimulation, just to name another one that you might be familiar with. In an hour, like I said, I'll have a lot to cover. I'll try to explain the medical terms as much as I can, and I know that the Q&A will be later, but if you have any questions that, or maybe something is not clear, don't be shy. Just raise your hand, or even just talk and ask me the question as we go, so that we can all understand this complex topic, but also very fascinating. So before we get started here, I want to make a little promo for an event, a virtual event, unfortunately, that we're working on at the Western. And this is an event not just for our own patients. This is an event actually for any person interested in this topic, also caregiver, everywhere in the world. We call this two events Stimulating Brain Discussion on Deep Brain Stimulation, because we found that there are a lot of misconceptions and maybe excessive expectations about deep brain stimulation. So we designed two events. The first one for people that don't have deep brain stimulation and maybe are considering to have it, or they simply curious to know what it is. And the second event will be for people who already underwent surgery and they want to share their stories. And not all the times these stories are with a happy ending. Sometimes things don't do the way we want it. So I also want to give the opportunity to people that want to vent or complain about what happened to them. And again, this is pretty much aligned with what I said before. We need to talk to people. And this is something that we're doing in Toronto with the Patients Advisory Board that we have at Toronto Western. So a few years ago, we had the idea of creating a board of patients that are helping us steer the research priorities, or how to run the clinic. And I think this is very important. And I think every center should have a patient advisory board. So take note, if you're interested, of the registration link, which will be up and running, I think, next week on Monday. And the two dates, as you see, is November 3rd and December 8th. The first event is for people who didn't get DBS, and the second one is for people that had it and want to talk about it. Okay, so these are my disclosures, and that's the other issue of doctors. We all have conflict of interest, especially because I'm an advisor for many pharmaceutical and medical device companies. And I highlighted here the companies that with which I have some conflict related to what I'm going to say today. But like I always say, if you have a conflict with everybody, at the end of the day, you have no conflict. So I think this is a possible way to get away with it. So what is MRI-guided Fox Ultrasound neurosurgery? So this is an explanation through a video. As you see, the patient is wearing a special helmet, and he gets into a MRI machine like any other MRI machine. The patient needs to have his head shaved, and there is water running around the head so that the scalp and the skin and everything doesn't get too warm. And through the water, ultrasound can go through with no problems. So an easy way to explain what this is just saying that this is a very expensive microwave oven. It's $1 million or more. And what's the difference with your microwave at home is that we have over 1,000 beams of ultrasound. They're very weak. Each of them is very weak, but they all focus in a specific spot that is decided by the neurologist, neuroradiologist, and neurosurgeon, so that that particular area of the brain can be cooked, and you can actually kill those neurons. And obviously, we don't want to kill the good neurons. We want to kill the neurons that are causing the problems, like the so-called tremor cells. Tremor cells are cells that cause the tremor, and you want to get rid of them if you don't want to see tremor. So I'm Italian, and I came to Canada 8 years ago when this started. And Canada has been one of the first countries in the world where Fox Ultrasound has been used. And I always say that you should be grateful. As we discussed last night, we had a little gathering here. No healthcare system is perfect, but the Canadian one has a lot of pluses, including the fact that it's public. These are therapies that are very expensive worldwide, and you get it for free. There is an issue of wait time. We're trying to work on it. Look at me. I had to come all the way from Italy here to reduce the wait time, and I guess there's the idea of hiring more doctors in the future. And certainly one of the pluses is that we have access also through donations to new technologies, and Fox Ultrasound is certainly one of them. And there's a lot of support from politicians. I'm usually not very keen in talking about politics, but for instance, this Fox Ultrasound story started also because we had support from the ministry, and this is actually the day when this was started. And as you can see here, we had a formal event with politicians and all of that, and you can imagine. Okay, so before we get into what Fox Ultrasound is and what you can expect from it, I think I want to walk you through the 4 steps that, as a doctor, I go through anytime I see a patient with Parkinson's. So anytime a patient comes to see me, I have to go through 4 steps to understand whether this patient is good for an advanced therapy. So step 1 is basically answering the question, is this patient good for advanced therapy? And you can see there the inclusion criteria, the exclusion criteria. But in a nutshell, what we want to see is that the person that we have in front of us has Parkinson's disease. And this is why we need to wait a few years to make sure about the diagnosis. I don't know if you're familiar with conditions that can look like Parkinson's disease, but eventually they are not, like PSP, MSA. There are a number of other Parkinsonism. This is the way we call them. So we want to have Parkinson's disease. We want to see that the patient has been treated with enough medications and with the standard of care. And this is where the network works. I know a lot of neurologists in the community, and I have a frequent exchange with them. They are a very important part of the process because we know that they are trying their best to manage your problems with medications. We don't want to do these therapies in people that don't need them because these are more expensive, but it's not just that. They are riskier because they are invasive. So we want to make sure that the patient has problems. These problems are not treated anymore with the best possible medical care. And last but not least, and actually this is the most important part, we want to make sure that the quality of life and the functioning of the patient is impaired because of Parkinson's disease. As I mentioned last night, I spend a lot of time talking about life with my patients. This is what I call biographical history. I don't want to know about their tremor necessarily. I want to know what they do at night when they go home. I want to know if they go out with their partner, if they can see friends, and if they can work, if their income is steady and the same, or maybe if they're giving up on certain things like going on vacation. And obviously, there are many reasons these things can happen. But if the reason is Parkinson's, this is when the problem becomes my problem, and then the question is, okay, we need to see whether advanced therapies can help this particular person to lessen the impact of the disease on this issue with quality of life or social functioning. Exclusion criteria are kind of obvious. You don't want to do this in someone who is severely depressed. You don't want to do this in someone that attempted suicide the day before because you know that there's high risk of disappointment in these people after surgery, and they can actually have another attempted suicide. And it happened, especially in the past, when we weren't really knowledgeable about this problem. The other thing that we look at is expectations. If the patient wants to have, for instance, Fox Ultrasound, because this way the next day he can run the marathon, we know that this person has excessive expectations, and this is not good for surgery, because necessarily this person will be disappointed after surgery. And also we look at caregivers and the family. Those are an integral part of the team. Without a good caregiver or a good care partner, we don't do what we do. Or maybe we do things in a different way. For instance, deep brain stimulation, particularly of a target called subthalamus, I will never do it in someone that lives alone, for many reasons. If you want, we can talk about it. On the other hand, Fox Ultrasound, maybe you can do it, because with Fox Ultrasound, as you see in a second, there is no need to do programming. And you get the procedure, you go home, and you might need to see the neurologist from time to time, but certainly you don't need someone next to you to constantly monitor your condition. So this is an important part of the discussion about step one. So is this a good patient for advanced therapy? And these are the advanced therapies that we have right now. We have deep brain stimulation, and together with it, I will also include the so-called lesional therapies. Lesional therapies includes 3 other procedures, and Fox Ultrasound is one of them. So you have deep brain stimulation and 3 other procedures, and they all target the brain. So this is neurosurgery. The second one is the infusion of levodopa in the intestine, which is known in Canada as duodopa. The third one is subcutaneous apomorphine. You don't have it in Canada. It's mainly used in Europe. You don't miss much. In the future, we'll probably have a new type of subcutaneous infusion of levodopa. So this is probably coming to Canada in a year and a half, and probably Dr. Jog will tell us later about it. So step 2 then is, what is the advanced therapy that you want to choose for this person? And now I need to make sure that you understand that no therapy is better than the other. Our job is to match the best candidate with the best therapy. And this is why we also spend time telling people about what's on the table for them. I never want to leave the patient with the idea that, okay, it's DBS, that's it. I don't have any other solution. I always mention all that is available, including experimental trials. Right now in Toronto, we're running an experimental trial with stem cells, for instance. So we say all that is available, plus what is available in terms of research. And as I mentioned before, there are a bunch of options. There is deep brain stimulation. There is ablation. Ablation means killing neurons, lesioning the brain. And this can be done with 3 different techniques. There is LCIG, which is levodopa, carbidopa, intestinal gel infusion, which is duodopa. And then there is apomorphine, but we won't talk about it. For each of these therapies, there are supportive criteria. So deep brain stimulation, we tend to do it in people that have bilateral problems, because deep brain stimulation can be done on both sides of the brain. We tend to do it in people who are very young, because over time we might need to adjust the settings. We might need to increase the strength of stimulation. As I said already, we want to have supportive care partners. And then there are a number of exclusion criteria. We don't want to do this in people that can't travel, can't come to see us often, or that have brain atrophy. So the brain is shrinking, the brain is showing the effect of age, or there are little strokes in the brain, because we know that the brain is more frail, and we don't want to do much with it. We don't want to insert any electrode in it. Ablation, and Fox Ultrasound is one of them, is indicated particularly for people that don't want to have anything inserted in their body. They're afraid of neurosurgery, or the classic ones at least. They can't come to see us often. They have mainly unilateral problems, because these therapies can be done for safety reasons only on one side of the brain. I won't talk about the other options, because it's not the focus of today's presentation. I also want to make a point about aesthetic consideration. Quality of life is a lot of things, and this includes aesthetics. I always make sure that people understand what this will entail with respect to their body when this is eventually done. For instance, if you have my same haircut and you underwent deep brain stimulation, you will have 2 little bumps up here, and some people don't want them to be visible. Or if you like to wear, dresses with, this is especially for women, of course, when you can see more of your skin, your shoulder. If you have deep brain stimulation, you will see the scar of the battery, And that's fine, but I want the person to know beforehand what this will look like, even from an aesthetic standpoint. With Fox Ultrasound, you don't have this issue. Actually, very recently, we did Fox Ultrasound in a bald man with a card dealer at the casino, and he didn't want to look like he had some sort of chip inserted in his body. He thought that it would be kind of awkward for people coming to the casino, so he went for Fox Ultrasound, even though he was in his 40s. And this is an exception to what I said before, when I said that for younger people, we tend to prefer at least deep brain stimulation. So these are the 4 different neurosurgical procedures that I've mentioned so far: deep brain stimulation, focus ultrasound, gamma knife radiosurgery, and standard thalamotomy or lesions in the brain, the standard one, the classic one. So 4 procedures. The first one is deep brain stimulation, which, as you probably know, means inserting electrodes in the brain. So it's an invasive procedure. There is some drilling. There is a part of the operation during which the patient is awake. And then there's general anesthesia, which is needed to insert the battery in the body. So like I said, this is requiring general anesthesia. It is invasive. It includes inserting devices in the body. And has a lot of pluses, but also a lot of downsides, as you can imagine. One of the pluses of this therapy is that this is not an irreversible procedure. So there is some sort of reversibility because we are providing stimulation. So if things don't do well, we can turn it off, we can turn it down, or we can turn it up in case of problems over time. So this is the reason why deep brain stimulation is used so much, because we can change things over time. The other 3 that I mentioned have something in common. As I already said, these are lesional therapy. Those are causing ablations. We're killing neurons. So these 3 procedures create an irreversible lesion in the brain. And that's the big problem with these 3 procedures. You get what you get. If it works, fine. If it doesn't, or if it does cause side effects, then you're stuck with the side effect. Ideally forever, but in most people, I would say, over time, things get better. So irreversible for these 3, the lesional ones. But then there are differences between these 3 different procedures, of course. The very first one that started in the 60s, last century, is the standard lesional procedure, radiofrequency-based. Words like thalamotomy, polydotomy, I don't know if you heard these words before. And this is done in an invasive manner. So the neurosurgeon opens the skull, insert a probe in the brain. This probe is used to burn the neurons using radiofrequency. And then this probe is removed. So nothing is left in the body. There's no general anesthesia, but there is an invasive procedure because something has to get inside. The other 2 are eventually doing the same thing, killing the neurons, but they do it in a non-invasive fashion, or I should say less invasive fashion, meaning that there is no opening of the scalp, there is no opening of the skull, and we're killing neurons from far, either shooting radiation, which is gamma knife, or shooting ultrasound. Remember the famous microwave oven I mentioned? This is focus ultrasound. So focus ultrasound is a newer way to do an older procedure, which is the ablation of certain body part, in this case, parts of the brain. And obviously for these 3, there is no general anesthesia. This is the other reason we use them in people that are maybe frail, old, and they can go through a whole operation with a general anesthesia involved. Now, step 3, in case I decided to go for a neurosurgical procedure, fine, but where do we insert the electrode? Where do we do the lesion? And there are at least 3 main targets in the brain that we need to be familiar with. One is the subthalamus, or STN. The other one is the Globus Pallidus, or GPI. And the other one is the VIM, which is a part of another zone of the brain called thalamus. Obviously, depending on where you go, or depending on your target, you may expect different positives, but also different side effects. And probably the best way to explain this, the differences, is to show you how they look like in the brain. So the first one is the thalamus, and you basically want to go there anytime you want to get rid of tremor. Any type of tremor, that's the target. Either you have Parkinson's tremor, essential tremor, multiple sclerosis tremor, you name it, the target is the thalamus, particularly this part of the thalamus called VIM. And with this procedure, you only get rid of the tremor, nothing else. The other one is the subthalamus, which, as you can tell from the name, is underneath the thalamus. And this is a powerful hub in the brain. This little nucleus has a lot of functions in the brain. And this explains why from a procedure in the subthalamus, you can get a lot, but you can also risk a lot, because this is an important structure. And when it comes to Parkinson's, if you stimulate or if you lesion the subthalamus, you have an improvement of tremor, you have an improvement of rigidity, you have an improvement of slowness. You don't have an improvement of dyskinesias. You can actually cause dyskinesias, but most people don't have this problem anymore because lesioning this target or stimulating this target improves the symptoms of Parkinson's, and therefore the neurologist can lower the medications up to 70, 80%, and that's why dyskinesias improve. The other target is the globus pallidus. The globus pallidus is a little bit like the subthalamus, but is less effective and safer. It's mainly a motor target, so we mainly tap into motor problems, and there's a reduced risk of causing behavioral problems, cognitive problems, stuff that you can see with subthalamus. So we usually go to the pallidus anytime we're dealing with a patient that needs something like subthalamic one, but is a little frail, is depressed, he has a little bit of memory problems. So we want to play safer. We want to get something, but in a safer manner, and we go to the pallidus. Since the effect of the pallidus is less important compared to the subthalamus, at least, we are not allowed to, we can't reduce medications. But this doesn't really matter to dyskinesias because the plus of the pallidal stimulation of the pallidus or lesioning of the pallidus, is that per se stops dyskinesias or improves dyskinesias. So we don't lower medications because we can't, but dyskinesias improve anyways. So these are the three targets. And this is how they look like when you do Fox Ultrasound of these targets. What you see in A over there is the thalamus, and this is a lesion, an ablation in the thalamus that mainly improves tremor. We call this thalamotomy. Thalamotomy means lesioning the thalamus. What you see in B is the same thing towards the pallidus, which is polydotomy, and obviously it's in a different part of the brain, and this is how it looks like at the MRI. What you can see here is the subthalamotomy, so the lesioning of the subthalamus, which is rarely done, and I'll tell you why, but I'll say a few words about this later. Step 4, which I think is the most important step. When it's time to do these procedures, Fox Ultrasound, DBS, duodopa, you name it, when it's time to do this? Well, this was a difficult question in the past. We now know the answer, and the answer is as soon as possible. If the patient is in your office and is deemed to be a candidate, there is no reason to wait. Obviously, you don't have to do it when it's not needed, but if it's needed, and I told you when, before, step 1, then it's time to do it. Because it's known now from papers, from publications, that if you do earlier, you gain quality of life earlier, and over time, this also improves your progression in a way. Not because these therapies are disease modifier, but because if you get the procedure and you have more stamina and you can go exercise and if you can go see your friends and you can keep your work, you have a much more positive outlook towards life. You exercise, you reduce the medications, and this is now shown to reduce the number of falls in the future, the number of issues like hallucinations that are caused by medications. So it's another way to get into a virtuous circle through which you exercise more and therefore your future is a bit better. So that's the other reason to do it earlier. Okay, the next slide is not advancing. Can you? It's happening? It's a little bit of freezing on the presentation. Is it happening? Okay. Oops, let me go back. This is just again to show you how the procedure is done. This is Fox Ultrasound. And what you see in this video is a neurologist. His name is Professor Obeso. He's actually a Cuban neurologist. He used to practice in Cuba. And in Cuba, since they have issues with healthcare, I mean, particularly with economical support, they do a lot of lesions. They don't do Fox Ultrasound because it's too expensive for them, but they do lesion the good old way, going inside and killing the neurons with radiofrequency. And that's why they have a lot of experience with lesions. And this doctor, Dr. Obeso, now works in Madrid, where they have a Fox Ultrasound machine. And this is just to show you that the patient is awake, and the neurologist or the neurosurgeon, I mean, anyway, a doctor is with the patient because you want to check if the patient is doing better, real time. And that's one thing, important thing of Fox Ultrasound, that the effects of Fox Ultrasound are right away. That you can see them right away, which is in contrast with another procedure that I mentioned, gamma knife radiosurgery, which uses radiation to kill the neurons from far. We don't use it too much anymore. One of the reasons is that you don't see what happens. You need to wait months because radiation takes time to kill the neurons. And this is obviously what doesn't happen with Fox Ultrasound. I don't know if you've ever seen this graph. This is something that was developed by the Gardner Foundation. This is the hype cycle, so-called, of any technology. So anytime you're dealing with a new technology, you have a new iPhone or a new TV or a new fridge, whatever, or a new device to treat Parkinson's, you go through this. You go from a peak of inflated expectation, and this is what happened at the very beginning. This is the very first paper published by Toronto Western in the Lancet Neurology. And when this was published, everybody was so excited about this. It went to the news, media covered this quite a lot, and I'm sure you heard about it. And this was a little bit of a problem to us because we had so many referrals, because the idea that people were getting about Fox Ultrasound is that it's like going to the barber shop or to the hairdresser. You go there, you sit down, they do the procedure, you go home with no problems. But this is surgery anyways. It's a surgery without opening the scalp, but it is still an invasive procedure. And then there is a lot of interest, and this is just a little graph showing that a lot of publications came up to discuss this new technology. And then people started to be a little disappointed because they didn't see all these benefits that they thought they would see. And there were publications like this one claiming that Fox Ultrasound is actually one step backwards. It's not progress. It's a new way to do something very old that we didn't do anymore, lesion in the brain. And finally, we're now getting to know the pros and the cons of this procedure. And there are a lot of pros and a lot of cons, of course. But one of the pros is that this is a very versatile procedure, which is approved for many indications. In Canada right now, it's approved for essential tremor. So for treating tremor in essential tremor, but it can also be done in other tremor conditions, including tremor in Parkinson's. But also Parkinson's, it will soon be an approved condition with a different target. It won't be the thalamus anymore, it will be the pallidus, and you already heard this term before. But there are countries like Korea where this is approved for depression, pain, OCD, and little by little, many more countries are now getting this procedure approved for many indications, including psychiatric conditions. So as I mentioned many times, this is a new way to proceed to do a procedure. What you see on your right is a patient that underwent a very classic thalamotomy many years ago, 20 years ago, which is the arrow radiofrequency. This is what RF stands for. And then this man with Parkinson's tremor needed something for the other side. It was too dangerous to do a lesion on both sides, as I mentioned already. So this man underwent deep brain stimulation, which is that little white dot. That's the electrode. And as you can see, it's in the same place. It's just on the other side. And the effect was the same. Now, if you look what's written, what's on your left, under Fox Ultrasound, FUS, you will realize that the part of the brain that is targeted is the same. It's the thalamus. And this is how the lesion looked like the first day. And then over time, the brain recovers, and you don't see that lesion anymore. And there's actually an evolution of the lesion over time. And we are now getting to know better, because we obviously do a lot of investigations in these patients, a lot of neuroimaging, how big this lesion needs to be. Because if the lesion is too small, the patient doesn't have any side effect, for sure. Maybe the tremor improves, but over time, the tremor comes back, because the brain always tends to heal itself. And the brain says, oh, something happened to me here. Someone wanted to kill my neurons. And the brain tries to little by little recover, and this means that the tremor comes back. If the lesion is too big instead, you have side effects, the tremor goes away, it will never come back, but the brain won't be able to recover from the side effects. And I'll tell you about the side effects in a second. So what you need to have is a lesion that is not big enough to cause an irreversible problem, but it's big enough to treat the tremor forever, in theory. So these are the very first studies showing efficacy in essential tremor. What you see on your left are the tremor scores. So this is the tremor. The higher the line, the more the tremor in 15 people. And as you can see, all people improved. But you can also recognize that some of them over time started to have some tremor back. And this is something I'm going to go back to in a second. The same cohort, the same actually group, did a so-called sham trial, sham-controlled trials. I don't know if you heard these things before. But an issue that we all face is placebo effect. So simply because you are in a machine and someone is telling you we're going to do something to help your tremor, you might feel better. So in this particular study, the one you see on your right, some people underwent the sham procedure. So they pretended to do the procedure for 4 hours in the machine, and the other ones instead underwent the real procedure. And as you can see, people that underwent the sham procedure didn't do any better. People that underwent the real procedure improved. And this is how we got the approval. This is another interesting way to look at the data. What you see here are individual patients. So each of these lines is the amount of improvement. The higher the bar, the more the improvement. And as you can see, there is a huge variability. And this is something that happens all the time. Anything we do has variability because everybody's different, because every procedure is done in a slightly different way. So not everybody improves 100%. Not everybody worsens or doesn't improve. And this is why doctors, when you talk about outcomes with patients, we always say, well, on average, we talk about averages, which doesn't really mean much to you. I realize that. But the reason is because there is variability. As you can see here, there are few people that even worsened. See the bars that go down after the procedure? They got worse. But the majority, as you can tell, improved because the bars are going up. But the improvement is variable. And this is what happened 1 year after the procedure, 2 years after the procedure, and we'll see in a second also the 3 years after the procedure. Have you heard the term meta-analysis? You know what it is? Meta-analysis means that a researcher, a group of doctors say, okay, let's see what's been done so far. So they put together all the studies done until this point, and they do an average of the studies. So this is a meta-analysis of the thalamotomies done using Fox Ultrasound for tremor patients. And you can see that the average of all these studies, the 1 year mark, is an improvement of tremor of 62%, which is pretty good. These procedures I'm telling you about are way more effective than any medication, so they're highly effective. This is our experience 2 years, a 2 years mark, and I want you to pay attention to the black bar. These are the people with an improvement of tremor higher than 50%. And as you can see, the first month, a lot of people improved, more than 50%. But if you see what happens 2 years later, you see that only 35% of these people have an improvement of tremor that is greater than 50%. The majority still has an improvement, as you can tell. But this is just to say that if the brain heals too much, then you have the problem back. Remember I mentioned the 1 and 2 years outcome in the studies done in the States. The same people have now published the 3 years outcome. These are, again, people with tremor. And as you can see, there is still a huge variability, and disability remains improved, which are those yellow bars. What about the side effects? The main side effects on any procedure targeting the thalamus, including Fox Ultrasound, are balance problems, speech problems, tingling, pain, weakness. It's like having a stroke on one side. But the main ones are really balance and speech problems. And what I found interesting in this particular publication with a follow-up of 3 years is that some people that had balance problems and was deemed at this point, these people were deemed at this point to have a permanent problem, actually some of them improved. So this means that the brain can still heal in case of a permanent or supposedly permanent problem. Obviously, we don't want these permanent problems, but you need to know that Fox Ultrasound, being a one-shot procedure that lesions neurons, can induce, indeed, permanent problems. And I'll tell you about the percentage of it. This is the longest follow-up we have so far done in Korea. And these centers have done amazing stuff. because looks like they all do well. This is the tremor scores and the disability scores, and as you can see from baseline, they're all doing much better. And this center is also saying that they didn't have any side effects, which is quite strange to believe, to be honest, but this is what they say. And actually, if you look at, again, a meta-analysis of the side effects published so far, when we target the thalamus, you see, again, the problems that I mentioned before. I want you to have an idea of the frequency of these problems. Let's have a look at the severe column. And you can see that in total, only 1% of this group of over 180 people analyzed, only 1% had severe side effects. The majority had moderate or mild side effects. Mild quite often, as you can see. Up to 80% of people had some mild side effect. One of the first patients that we operated on in Toronto still has a little tingle of his lip, on the side of his lip. Not a big deal, but in theory, that's a side effect. The patient is happy because the tremor is much better. As I said before, if you see side effects, you know that the tremor will be better. This is another meta-analysis showing what's the prevalence of the other major problems that I mentioned before. When it comes to tingling, which is called by doctors paresthesias, it's 15% at the 1-year mark. When it comes to imbalance, it's 10%. So 1 in 10 patients has some balance problems after Fox Ultrasound. And this is why we don't usually do it in people with balance problems at baseline, because we're afraid of making that even worse. So these are the numbers at the 1-year mark. If you have a look at the same numbers a month after, you see much higher numbers, because it's normal in a way that the brain needs to recover right after the procedure. If you see at the same figures a little later, I mentioned the 3 years mark before, you might see that these numbers are a little reduced. I mentioned many times that this procedure, for safety reasons, can only be done on one side. And this is coming from the history of lesional procedures. In the past, in the 50s, in the 60s, we knew that if you were to do the procedure on both sides, you were looking for troubles. But back then, we didn't have the fancy MRI machines we have these days. We have now a better way to look at the brain and understand where to go. And this is why we are now trying to do these procedures, Fox Ultrasound in particular, on both sides at the same, not at the same time, but on both sides in the same patients. We do it in a staged fashion. So we do the first side first. We make sure that the patient doesn't have balance problems, for instance, that things are doing well. And if the patient needs treatment for the other side, we wait at least 6 months, and then we do the procedure on the other side. And these are the MRI scans of the first 10 patients that we included in a study. These graphs are mainly just to say that the quality of life improves even more, the tremor improves, all things that you can imagine with a bilateral procedure. 7 patients out of 10 had mild adverse events, and gait problems, fall, were seen in 2 patients at 1 month, and dysarthria means speech problems in 1 patient. So again, this is not risk-free, but it's pretty exciting to see that this is something that can be done now on both sides. One of the endpoints of the study was the question, would you do it again? And all 10 patients said, yes, I will do it again, even the ones with side effects. So this is telling you that this is pretty exciting, and perhaps we're going to do more and more in the future. This is one of the first patients that was enrolled in this particular study. This is a man from Alberta. They had to come all the way to Toronto to have it done. In Alberta now they have the machine, but back then they didn't have it. So what you see on your left is the way he was doing before surgery, and as you can see, has tremor on the right and on the left. What you see in the middle is the video after the first procedure, which obviously targeted the right side because this man is right dominant. And the tremor was much better on the right, but it didn't improve, of course, on the left. And what you see on your right is the last video we took after the second procedure to treat the tremor, not just on the right, but also on the left. Okay, so far I've mentioned a lot about essential tremor. The same applies to Parkinson's. And I wanted to talk about essential tremor because being this the first indication of Fox Ultrasound, we know a lot more about this for essential tremor. But the same applies to Parkinson's. But I found this very interesting. This is the very first sham control study using thalamotomy for Parkinson's tremor. And now you know what sham means, right? It's a way to get rid of the placebo effect. And this is the biggest difference with essential tremor. Remember the first graph I showed with the sham surgery of essential tremor patients, no improvement of tremor whatsoever. Look what happens in Parkinson's instead. People that received the sham procedure, which are the white bar, also improved. And that's something very important to be aware of in Parkinson's disease. Parkinson's patients are very sensitive to placebo. And that's good, but also bad. It's not just bad for studies, because obviously if you have to deal with a huge placebo effect, you don't really know what's the effect of the real procedure. But it's also bad because from time to time, you will see on the internet, on TV, or a friend of yours could tell you, oh yeah, why don't you try, I don't know, onions. Eat onion every day, you'll do better. If you do it, you'll get better, and that's placebo. And in a month, you won't get the same benefit anyways. And obviously, if you eat onions, nothing major is going to happen. But if someone comes to you and say, wear this special bracelet, it costs $100, and you'll feel better. And you know what? You can even try it first for a week. If you're happy, you pay me and you keep the bracelet. They do it because they know that there's placebo. And the first week, you do great, and you pay the $100. You go home with this useless bracelet, and a month later, you don't see any benefit. So be aware of the placebo effect. And that's why doctors do studies with a placebo-controlled arm. This is all the time when patients tell me, oh, I'm going to be a guinea pig. No, it's not that. It's just we need to get rid of placebo. And it's not because we want to be mean to patients. Doctors don't even know what's the real therapy sometimes. So this is called double blind, when neither the doctor nor the patient knows what's the treatment allocation. And this is because we're humans, and we know that when something is done to us to make us feel better, we feel better. So a few new things about Fox Ultrasound. We are now doing it in a lot of other conditions, not just essential tremor or Parkinson's disease. We're doing it in any other sort of tremor. And we know that it's pretty safe, to the point that we're doing it also in people that are over 90 years of age. And it's also cost effective. And actually one of the study, Lee et al., it's been done, and I helped them by one of the offices that the Ministry of Health consults to see if something is cost effective. And it was published showing that Fox Ultrasound actually makes sense because the community saves money, because you reduce medication, people do better, blah, blah, blah. And we also know, as I mentioned, that some people don't do well after the Fox Ultrasound. They do well initially, but then the problem comes back. And we know that in these people, you can repeat Fox Ultrasound one more time, or you can do something else, like deep brain stimulation, for instance. The very first person that was published with a repeated Fox Ultrasound was a patient of ours with Parkinson's disease. You see this man with Parkinson's tremor on the right, and a week after the procedure, the tremor is gone. He was so happy. But a few months later, the tremor came back. And you see that the patient has more tremor on the right. This is a year later, but also on the left. And the last video you see in the corner on the bottom right is the patient 3 months after the second repeated Fox Ultrasound on the same spot. So this is doable in case the problem comes back. This man, however, had a little side effect after the second procedure, which makes sense because you're killing more and more. But overall, he was happy with the tremor control. Was he happy in general? Remember, this is a thalamotomy, so we are killing the neurons of the thalamus. And if you paid attention, you know that when you treat the thalamus, you only get rid of the tremor. And unfortunately, the disease progresses and causes other problems. And this is why, if you look at the disability, which is the light gray bar, even though the tremor improves, which is the gray bar, the disability goes up anyways. And this is because the disease progresses, and the thalamotomy alone is not able to keep track of all to take care of all the other problems. This is just an example of what we've done in other conditions. These are two patients with dystonic tremor. It's a brother and a sister, and I figured out it was faster to do the video together, as you can see there. This is the first time I did this, which is quite interesting, I found. And they did better, tremor-wise. This is writer's cramp, which is a problem with writing. It's a dystonia that affects the writing, and also you will see an improvement of the writing. Still better than mine, even a baseline. And now this is polydotomy. Remember, thalamus only take care of the tremor, but we want to get rid of all the other problems if possible. And this is why we go to the pallidus. Remember, the pallidus is the other target that does something similar to the subthalamus, but is a little safer. That's why we're doing polydotomy. And with polydotomy, this is the very first paper on 10 patients. 8 were successfully treated. 2 patients could not be treated, and I'll tell you in a second why. But there was an improvement not just of tremor, but also rigidity, slowness, but remember, only contralaterally, only on the opposite side, not all the body, but just the side opposite to where the procedure is done. And also dyskinesias improved, because you remember, polydotomy or pallidus or GPI DBS improves dyskinesias. So they did well, but 2 patients could not be treated. One, because not enough ultrasound could reach the pallidus, and the other one is because of what happened in the MRI that you see here. So you see those arrows? Those are areas that were lesioned by the Fox Ultrasound, but those are not the pallidus. The pallidus is actually far away from those arrows. Those are structures that were on the way, and for reasons unknown, were burned by the Fox Ultrasound. We now know why this happens, and we know why in some people it's more difficult to do polydotomy. Anyway, this study inspired a larger trial, which is now completed, this one, PD0006, and this is a trial that's been done in many centers, mainly in the States and in Canada. We were one of the centers, and this trial showed an effective therapy for Parkinson's signs, especially for dyskinesias, especially for one-side procedure, and this is why now the FDA is about to approve this for Parkinson's therapy. So thalamotomy is approved for essential tremor and Parkinson's tremor. FDA is now going to approve polydotomy for Parkinson's disease, and usually when this happens, also Canada follows, and we'll have polydotomy approved for Parkinson's too. But why is the pallidus a little trickier than the thalamus? And this is because of geometry. The thalamus is at the center of the brain, and you can imagine that when you focus beams of ultrasound, it's easier to go to the center. The pallidus, on the other hand, is a little lateral. So all those ultrasound need to travel a long distance, particularly on the other side, to get there, and sometimes this is not enough. Or if you go higher to lesion that part, those beams they are going towards the pallidus, which is far away, lesions standing along the way. This is very rare. It's been reported so far in 1 person, as I said, but in theory this can happen. Remember I told you about subthalamotomy. Subthalamus is a powerful target, and so far we don't lesion it. We don't want to kill anything there because it's an important structure. But remember Dr. Obeso, the doctor that was in Cuba? Since in Cuba they do subthalamotomies because they had nothing else to do, now that he's in Madrid, he said, why don't we do the same with Fox Ultrasound? And these are the first 10 patients where subthalamotomy was done. And pay attention to the blue bar. The blue bar is the contralateral motor problem of these patients, and you see that after unilateral subthalamotomy, the blue bar goes down a lot and remains stable a year later. So these are people that do very well. Tremor, bradykinesia, which is the slowness, rigidity, these things all improve. But I also need you to pay attention to the red bar. Red bar is showing the signs, the symptoms on the other side, on the side that is not treated. And you don't see much there. But what I want to mention here is that there is a huge asymmetry at baseline. So focus ultrasound of the subthalamus is mainly useful when the disease is very asymmetric. That you have problems mainly on one side. So let's say I have a lot of issues on my right side and the left side is pretty good, and I'm taking 1,000 milligrams of levodopa to improve my tremor. If I do the focus ultrasound to get rid of this problem on the right, I lower my levodopa to 300 milligrams maybe a day, and this is still good. No dyskinesias, maybe because we lowered levodopa a lot. Maybe the left side is shaking a bit more now because we lowered levodopa, but overall I'm doing well, right? I'm symmetrically good. But if I'm shaking a lot and having issues with Parkinson's on both sides, and I do this on one side only, one side gets better, but if I reduce the medication, this one gets much worse. If I don't reduce the medication, this one has dyskinesias. So this is why for this procedure, we want to have people who are very asymmetric. Maybe in the future we'll be doing bilateral subthalamotomy, exactly like we are now doing bilateral thalamotomy. So time will tell. We now know that this works, subthalamotomy, because the same group in Madrid also did a sham control procedure, and now you know what it is. And guess what? People that underwent the sham procedures only had a little bit of placebo, but they didn't really improve much. The ones that underwent the real procedure improved. Now, I don't know if you noticed, I guess you're now familiar with this bar that go up and down, right? There is a blue bar, a little blue bar with a blue dot underneath. I don't know if you see it at the bottom. That patient was in the scanner, was getting the therapy, but he had a panic attack. Have you ever done an MRI? I guess most of you have. You need to be in a very tight tube for 40 minutes, 45 minutes. With Fox Ultrasound, you got to be in there for 3-4 hours. Okay? So you can have a little rest from time to time, but you need to be there for many hours. We're getting faster now, 3 hours maybe. Why? Because we don't want to kill the neurons all at once. We just increase the temperature a little bit, and we can actually keep track of the temperature in the brain, so that these neurons, they're a little pre-cooked. They don't die, but they don't work because something is off. They don't know what's going on. They stop working. So we can see if the patient is doing better. We can see if there are side effects. And if we see that there are no side effects and the patient is doing better, we know that we are in the right spot, and we increase the temperature again in that particular spot for a little longer so that we're sure that we kill those neurons. And this is not just one time. This is called sonication. This is done 14, 17 times. So it's a lot of trial and error and monitoring of the patient. That's why you need to be there for 3-4 hours. And anyway, one of these patients had a panic attack and had to abort the procedure. Now, subthalamic stimulation, when you do DBS, can cause dyskinesias. Subthalamic lesion, like you can do with Fox Ultrasound, can also cause dyskinesias. The problem here is that while with deep brain stimulation, you can lower the stimulation, you can turn it off. With Fox Ultrasound, you can't revert. So if you have a dyskinesia, then you're a little bit in trouble. Usually with time, things get better. Let's have a look at what happened in this trial. So 15% of the people that received the procedure had dyskinesias 4 months later. So this means that these people have more dyskinesias on one side up to 4 months later. But of these 4, half eventually improved. So they didn't have dyskinesias anymore. So it tends to get better. Still, a year later, 7% of the people that received subthalamotomy still had these new dyskinesias that didn't have before. So mind that. Then you see a number of other problems, the usual one, gait issues, balance problems, speech problems, weight gain, that sometimes happens when we deal with the subthalamus. But have a look at the numbers. Overall, I would say the safety profile is pretty good. But you can have dyskinesias, as I said. This is one of the first patients that was treated by this group in Madrid. You see the way he was doing in the off state on your left, and you see on the right that he has dyskinesias affecting his right arm. It's not the right arm. It's not too bothersome, and 6 months later, the dyskinesias are gone. Unfortunately, not everybody, as you heard, has this outcome. And there are possible ways to mitigate this risk that I'll spare you from for the sake of time. There is a group in Switzerland that is quite famous on the internet because they are doing a slightly different procedure, targeting the area that is right above the subthalamus. It's basically between the subthalamus and the thalamus, and they claim great results with no side effects. I hope they're right, but it's a little too much for a claim. I always wonder when I see publications where the author said we didn't have any problem, because most of the time they lie. So, but this is just my personal opinion, of course. I might be wrong. Anyway, this is another interesting approach, also because they claim that you can actually do this bilaterally right away. So without staging the procedure, in some cases they have done bilateral procedure, aiming at improving not just tremor, but also rigidity, slowness, in both sides in some people with Parkinson's. As I mentioned before, MRI is really exploding. We have a lot of new techniques, and the Fox Ultrasound is MRI-guided. So we do this in an MRI machine. So this gives us a lot of opportunities to do a better job and also to understand what's going to happen. So we can use tractography. Tractography is basically a way to see where the neurons are going, and we can actually keep track of these fibers, see where they are, and we can target particular fibers. But we also have maps, like you can see on the right, or where we need to go to have some effects, where we don't need to go to avoid side effects. So we're learning, and we're now building more and more sort of an atlas, or where we need to go and where we don't need to go to have an improvement. And we now know what particular areas, in this case of the thalamus, can cause particular side effects. This is the very first patient that was treated in Canada. And you can realize there are journalists, there's the press. This is a patient with essential tremor. I'm showing this man for a particular reason. So this man underwent the very first thalamotomy, and back then, as you can imagine, we did it on one side only. He has tremor on both sides, but have a look at what happens right after surgery. He has a much better control of his tremor, not just on the right hand, but also the left side. So this tells us that sometimes doing the procedure on one side of the brain only is enough to improve both sides. And this is a bit of a mystery. It's not, in the end, because we know that the brain has a lot of crossed functions, but the mystery is why this happens in some people and doesn't happen in other people. The same will apply to midline problems like head tremor or head dystonia. So it's very variable, and we're trying to understand why this happens. I mean, this is very complicated, but this is, again, those famous bars on the left showing the improvement of the ipsilateral side, on right, the midline problems. And we were able to locate particular areas in the brain associated with improvement of areas that you didn't think would improve. So we're now taking advantage of this type of information because maybe in the future we'll be able to at least try in a better way to improve symptoms bilaterally, only treating one side. We'll see. Another issue that you need to be aware of is that not everybody can get this done. For instance, if you have an implant in your body that is not MRI compatible, forget about it. You can be in an MRI scanner, period, so you won't get the therapy. That would be one reason. The other reason is that some people have a different skull density. You want the skull to be dense enough. You want the bone to be dense enough, because if there is too much dishomogeneity in the brain, so there's not an homogeneous structure, the ultrasound don't get through in a predictive fashion. So they get deviated, or they get stuck in the bone, and they just burn the bone of the scalp. So we need to have a density of the skull that it's at least higher than 0.40. That's the number, it's the measure we use. Even though lately we have seen that in some people we can still do it, in people with a lower density of the skull. The downside here is that we need to burn for longer. The procedure is a little longer. Some people complain of pain at the scalp level. It's not impossible, but certainly it's a little trickier. This is something we deal with in about 15% of the time, of the patients. So this means that even if you say, I want to go and get Fox Ultrasound, if your neurologist says, yes, you're good for this, if you're good to go, you still have 15% chance that the procedure can't be done because your skull is not correct, it's not appropriate for this procedure. And we also see now that there's a distribution that it depends on age, but also sex of the patient. And guess what? Looks like men are less affected by this issue of a less homogeneous skull, or in other words, they tend to have a harder skull, which makes sense, I guess. So that's, I think, it's an important information to provide you with today. Okay, so towards the end of my presentation, I want to emphasize that anytime we deal with something new, obviously there's a lot of excitement, but there's a lot of information that needs to be provided, which is what I've done for this hour with you. And anything new has unknowns. So the idea that anything new is better is wrong. Anything new is exciting. It might be better than the past, but there are also unknowns that you need to be aware of. So what are the unknowns of Fox Ultrasound? Well, we don't know what happens in these people 10 years after. Can we reoperate on the same area? Can we lesion areas that are not very central, like the pallidus? Can we do bilateral procedure? Can we use MRI to guide a better procedure? Can we do lesioning of the subthalamus? Do we have any risk of bleeding? What's the effect of placebo? Those are the unknowns that I put in a paper that you see down there in 2017, okay? So this was almost 5 years ago. And I'm pleased to say that most of these unknowns are now better known. And this is why we need to do research. And it's actually pretty impressive to see so many green check. When I put together this presentation, I was actually pleased to see that. There is no green check about the bleeding risk. We know that the bleeding risk is extremely low, very low, basically impossible to have a bleeding. You can have a bleeding from something that gets into your brain, like deep brain stimulation. With focus ultrasound, it's been reported when focus ultrasound is being used to treat people with brain cancer. And brain cancer is known to have a risk of bleeding anyways. What I mean here with bleeding risk not being fully known are those people taking blood thinners. And I'm not just talking about aspirin or Plavix. I'm talking about anticoagulants. And some people can't stop the anticoagulants because if they stop, they have a risk of having a pulmonary embolism or a heart attack. So in some people, we can't do the procedure because we can't stop the anticoagulants. This tells you that we always stop anticoagulants or blood thinners when we do this procedure for at least 1 week before. But there are people arguing now that even if the patient is on anticoagulants, you can do it. Nobody has done it yet. In these cases, we do gamma knife radiofrequency. Remember the procedure that we use very little now, very, very seldom? That still has a role in people that are on anticoagulants and can't stop them because the radiation don't kill the neurons right away. They take some months to do it, which is positive in this case. What are the problems of focus ultrasound? Again, this is what I put together in 2017. Variable effect. I mentioned this, I think, enough. You remember all these bars that are not always at the same level, so it's very variable. Symptoms might get worse over time. In some people, there are persistent side effects. Some people may have an unpredictable response with a lesion in an area that you didn't want to lesion. It's difficult to treat both sides, as I mentioned. There are people with MRI contraindication, people with low skull density ratio, I mentioned already. There's limited experience. But I want to emphasize 2 points in particular here, because meanwhile, we got to know a bit better about these problems. It's not possible in patients with previous brain surgery. Let's say you had a deep brain stimulation. It didn't work well for you, whatever. And then you say, I want to have a focus ultrasound now. In theory, we need to tell you, no, we can't do it. Why? Because to do deep brain stimulation, the surgeon had to open the skull. So there is at least a part of the bone that is not homogeneous, is actually open, and the fear is that through that part of the skull, more focus ultrasound will get through, and we can lesion the brain more. But now we're getting to have information that in some people it's now possible to do focus ultrasound, even in case of a prior procedure. But the main one, and that's why I want to talk to you about this today, is the misperception of this as a safe option, of this as a non-surgical option. This is brain surgery like any other. It's just different. So I don't want you to go home thinking, oh yeah, I'm going to get brain focus ultrasound because it's the safest option. No, there are risks. And part of these risks is because of what doctors say. This is taken from a center. It's in Spanish. I don't know if you speak Spanish, but anyway, this is a brochure for patients in a center that I got to have from some spies. And see what they say there, that this is a non-surgical procedure. No, this is a surgical procedure. So part of the misinformation comes from the media, but also from doctors. And this is a publication already mentioned. I'll skip it. All I want to give you as a take-home message is that we have options on the table. There are at least 4 different ways to do brain procedure in people with Parkinson's. I mentioned them all. And as I mentioned before, our job is to match the best person with best patient with the best option, which doesn't mean that one is better than the other. It means that there are ideal candidates for each procedure. And this is what I do basically on a daily basis in my practice. Another positives of focus ultrasound that we didn't expect, which I call the MRI-G focus ultrasound effect, is that because of this, because of the fact that now the media is talking so much about focus ultrasound, we got so many referrals of people that never heard of even DBS. And now they come to see us because they want to see the same thing that they saw on TV. They often call it the laser therapy. And for some reason in medicine, anytime you use laser, it looks like a cool thing. This is not laser, this is microwave. But anyway, people come to see us because they want the laser. And we tell them, look, yes, you can do that, but there is also deep brain stimulation, radio frequency, blah, blah, blah. And because of that, we are doing more deep brain stimulation. People are getting to know more options that they didn't know before. So that's certainly a positive. Yeah, time is up. I just want to say that there are a lot of other indications for focus ultrasound. We can use focus ultrasound also to stimulate certain areas of the brain. This is an animal experiment where focus ultrasound is used to move a limb. You see that the limb of the rat there moving when the ultrasound is shot in a different way. So what I'm saying here is that focus ultrasound can also be used to understand how the brain functions and possibly to find new areas for stimulation, of deep brain stimulation, or for lesions with focus ultrasound. And there are so many other indications in the pipeline. A lot of other conditions are being, at the moment, treated, or at least tried to be treated with focus ultrasound. And this is a very interesting new application of focus ultrasound. This is going to be one of my last messages for you today, which is opening the BBB. BBB stands for blood-brain barrier. It's basically an envelope all around vessels, arteries in the brain that prevents any molecule to get in the brain. So the brain is trying to protect itself from toxins, from drugs. So this is why very few drugs can penetrate the brain, because of this BBB. Focus ultrasound can be used to open the BBB. So this way you can get new molecules to get inside the brain. It was on the news a few days ago at Sunnybrook in Toronto. They used focus ultrasound to make sure that some chemotherapy can get into certain brain metastases. And this was never done before, because this chemotherapy, even though they were effective in the rest of the body, could not be used for metastasis in the brain. These authors have opened the BBB so that the chemotherapy now can get into the brain and affect the metastasis. This is very exciting. Now, back to Parkinson's. Why is this exciting? Because part of the theories that we deal with now is that if you deal with cognitive problems like dementia, it's because certain proteins are stuck in the brain and they can get out. These are proteins like alpha-synuclein or amyloid. And now the idea is that if you open the BBB, you don't only make sure that you can bring something inside the brain, but you can also make sure that something gets out of the brain. And this is a very first publication of using this approach in people with Parkinson's and dementia to see whether some toxin can get out. And this is very preliminary, is open, so no placebo control, but it looks like some people also had an improvement in their cognition. So remember, you saw this before. And what I'm saying now is that depending on what type of applications of focus ultrasound you are talking about, you're at the different phase of the cycle. So for instance, for the BBB opening, now we are very excited. And we'll see in a few years where we are at. And for sure, this will be an exciting story. And maybe you'll be kind enough to invite me again to talk about it one more time. So these are the many people working with me on these things. And this is really a team effort, as you can imagine. These are all great people. And I'm really pleased to work with them at the Western. And this is again to thank you. And remember, if you want to join us for the event I mentioned at the beginning. So thank you, and I'll discuss questions later.